Good afternoon, everyone. My name is Wendy Farthing. I'm with the Maryland Living Well Center of Excellence. I serve as the Director of Community Integration for the Maryland Living Well Center of Excellence. And with us today, we are privileged to have Dr. Yassar. She is the Associate Professor of Medicine and Neurology at Johns Hopkins School of Medicine. She is a founding member of the multidisciplinary Johns Hopkins Memory and Alzheimer's Disease Treatment Center and is managed by the Division of Geriatric Psychiatry and Geriatric Medicine and the Department of Neurology. I've shared with you her bio in the link. Today, we are going to be talking about the effects on vascular risk factors, which would include hypertension, diabetes, and in mid and late life and their effects on brain health. And I am going to start sharing my screen. Asking that we will have an opportunity for Q&A at the end of this 30-minute presentation. And if you wouldn't mind, if you had questions regarding the presentation, to type them in the chat, and we'll make sure that we get to your questions after the presentation. So with that, if you are coming in, if you wouldn't mind muting yourself, I would greatly appreciate it, and we'll get started. 1 second. Here we go. Confirming that you can see my screen. And with that, Dr. Yassar, I will turn this over to you, and you can introduce yourself.
Yeah, thank you, first of all, for the nice introduction and for having me, and for everyone here who is at 4 o'clock decided to join. And I want to be very practical because I heard, from all profession, make it useful for everyone. So I was originally asked to talk about diabetes, but you will see there's more what we can talk, and I hope I make it very useful for all of you. So next slide, please. So, of course, I have nothing to disclose. I don't have any financial connections. So I hope it will be a non-biased talk. So when you hear about Alzheimer's disease and Alzheimer's neuropathology, you hear about the amyloid pathways. You hear about amyloid. And to the left is the amyloid, to the right is the non-amyloid. We all have amyloid precursor, which is in the middle, which is in the normal pathway. It's cleavage with the amyloid, with the alpha, and then it's being soluble, and there's nothing pathological going on. On the left side, you will see the amyloid pathway. When the alpha secretase is not stepping in, the first step is the beta secretase, and the second one is the gamma secretase cleavage. Sorry, first the beta and then gamma, and then you have the amyloid beta. First, you have the oligomers, then the fibrils, then the monomers. And so there you have that, next slide, the amyloid beta. So what we also have learned over time, that this process starts actually around 20 years before we even develop symptoms. So first we start to have an amyloid deposition, and there's also another abnormal protein, the tau protein deposition. And based on that, now we know there is an entity called preclinical Alzheimer's disease, when we have no symptoms, but all these abnormal proteins develop 20 years before. There's an entity called mild cognitive impairment when we already have some symptoms, but we are still functional. And then there's a full-blown dementia syndrome. Next slide, please. But over time, what we have learned from autopsy study and imaging study, that when people who come with a diagnosis of Alzheimer's disease, only 40% have Alzheimer's pathology. And the other 60% is everything else. But when you look at all the arrows and you add it up, I did add it up, around 20% adds up to vascular pathology. They have microscopic infarcts, they have atherosclerosis. So there is a vascular story going on. Next slide, please. So this is one of my favorite figure. So this shows that we need to consider Alzheimer's disease and also dementia in general a life course. And what we have learned that over time, 40% of Alzheimer's disease and also dementia risk is modifiable over life course. Of course, there's genetic risk we cannot change, but it starts already at birth, and over life with educational attainment. But you see here, I put the little, too bad I cannot show it to you, but I put those little red, yeah, thank you. And you see there midlife hypertension, and in late life, diabetes. So I will focus on those two. Next slide, please. So again, multi-target. So that's why when I was asked to talk about diabetes, I said, well, maybe it's not enough because we as doctors, we see these people, they just don't come as a one hypertension. When we talk to them and we treat them, we need to talk to them about, not only one disease, but about many diseases. And we need to really think about a multi-targeted approach. Not only, you see there are also other risk factors. There's, for example, hypercholesterolemia, there's obesity, there's diet, there's smoking, and there's also, as you can see, physical activity. So there are so many things we can talk to them and do in different stages of life to prevent and help dementia in late life. Next slide. So there are a couple of very good studies. So I pulled out some which I really like and it helped us. So hypertension and dementia risk. This Whitehall study is a study which came from England. It followed like servants from government servants, around 8,000 participants over 25 years. And it looked when you develop hypertension in your age 50, 60, and 70. And it looked when do you develop at one level of your systolic blood pressure, you develop Alzheimer's disease. And as you can see, I usually make it easy for you. When you see the circle, that is when you cross the line, that is when you increase your risk for Alzheimer's disease. The top panel, the panel A, shows that at age 50, when you cross around at systolic blood pressure around 135 and 140, that is when your risk for Alzheimer's disease increased around 30% in your late life. Interestingly, when your systolic blood pressure started to, increase in your age 60 or 70, there was no association with late life Alzheimer's disease risk. Next slide, please. Now, I'm sure you must have heard, or if you did not, there was a clinical trial. It was called the SPRINT trial. The parent trial, the intervention was intensive blood pressure control versus normal blood pressure control. The intensive blood pressure control the goal should have been 120, and the comparison group was the 140. And the outcome was all-cause mortality, cardiovascular mortality, cardiovascular event. And the study had to be actually stopped earlier after 3 years because the intensive clinic arm showed significant reduction in all-cause mortality and cardiovascular mortality. So there was a sub-study called the SPRINT MIND trial, and it had 8,000 participants, and the intervention lasted for 3 years, and the follow-up was only 5 years. And what you can see in the lower panel, there was a significant reduction in the risk for development of mild cognitive impairment by around 20%. There was also a reduction of possible or probable dementia, but that did not reach significance. And we think that maybe that was because we were not able to follow them up sufficiently. So the Alzheimer's Association and also the NIA funded this study to follow up the people for an additional 2 years. And I think maybe in another 1 or 2 years, we will get the results from this study. So, and the people who were in this in the arm with the tide controlled, those were the one who benefited from in terms of risk reduction. Next slide, please. Just, this is just further support. The study by my colleague Ruth Peters took all the randomized controlled trials, in not only the sprint came earlier, but there were some other randomized controlled trials like the advanced HIVET, progress SHAP, and assist Euro, and put them in a single data set, and did actually on a personal level analyze their data. And next slide. And found the found a very similar result, that it significantly reduced the risk for Alzheimer's disease. Now, this recent paper from Lancet Healthy Longevity showed that dementia, hypertension, contributes to for the dementia risk all in terms of life 7%. Do you remember the 40% risk? So hypertension by itself can contribute 7%. So we doctors, we primary care doctors, geriatrician, just by managing hypertension can reduce the risk. Now the question by how much, or what is our ideal systolic blood pressure, that is still not clear. We are still working on, is it 120? Is it 130? There was this only one blood, the sprint trial. That is the only trial which has been done, but we do not know that yet. So there's still work to be done. Next slide, please. Now, the question is, when you have hypertension, then you're obviously also on an antihypertensive, correct? So next slide, please. There were many, many studies done which looked also at antihypertensive medication. And there was a promise, particularly in the group called the ACE inhibitors and angiotensin receptor blockers. And there were two, just to save you, there were two recent meta-analyses, one done by my colleague and with me, Ruth Peters. And we found, actually, when we put them all together, there was no benefit when you were an antihypertensive medication user, when you were compared to an other antihypertensive medication user of any of these groups. So there was no any group benefit. Next slide. However, another group that at the same time when we did it, they found that when you had a history of hypertension, there was a benefit when you were on any type of antihypertensive medication use. In medication, there was no particular antihypertensive medication group which was better, but just treating your blood pressure was beneficial compared to not treating it. Next slide, please. And this benefit was not present when you did not have any history of hypertension. So it seems that maybe, this has to do something with treating blood pressure. Next slide. But most of the studies were done in late life. The follow-up was relatively short with the exception of one study. And do you remember, next slide? Do you remember when we talk about the benefit of the dementia risk reduction and particular hypertension, those come in midlife. So that really makes me wonder that the studies, we haven't really worked on them hard enough. We need to do more studies focusing on midlife hypertension treatment, more studies looking at these antihypertensive medication and midlife and late life risk. Next slide, please. Diabetes. So what is the idea? We know from studies that diabetes is also associated with increased dementia risk. And here's the hypothesis. The diabetes, of course, there are a lot of comorbidities, there are a lot of medications, and of course, there's a genetic predisposition. There are many pathways how the risk is increased. One is the vascular pathway. With them, you can have increased infarcts, and there's the vascular pathway. The other one is actually the Alzheimer's pathway. You have an insulin increased secretion, and with that, you have also, yes, thank you, decreased breakdown of amyloid. And there's, of course, glucose toxicity. And with that, you all put this together and you can have an increased risk for dementia. Next slide, please. So here's a lot of studies have been done with dementia, focusing on diabetes in late life and dementia risk in late life. And I'm circled that here. One study, again, from the same B cells, looked for any dementia and also looked at Alzheimer's disease and vascular dementia. And you can see that particular vascular dementia risk is significantly increased when you have diabetes in late life and dementia in late life. These are, a review article. It looked up at numerous studies, but also Alzheimer's disease. Next slides. So what is interesting, there was the same B cell as a review article, also looked at diabetes in midlife and dementia risk in late life. And there were some studies, there were fewer studies, but there were some found that, let's focus on any dementia, that they found that yes, if you have diabetes in midlife, your risk of any type of dementia in late life is increased. And one study confirmed that Alzheimer's disease was associated with, with diabetes in midlife, you had increased late life dementia. Interesting, there was no association found with late life vascular dementia. We don't have, few studies are done. Maybe we need to do a little bit more work on that. Next slide. This was a very, from the same Whitehall study. Again, very nice, long follow-up, 10,000 participants. They looked at age onset. So on the top panel, you see when they looked at people who were 55, the next group 60, 65, and 70. And then they also looked if you had diabetes, the third column looked at if you had diabetes more than 5 years, the next column 6 to 10 years or more than 10 years. And when you can see if you were age 55 and had diabetes over 5 years, you had a significantly higher risk for dementia, all-cause dementia. When you were over 60 years old and you had diabetes over 5 years and over 6 to 10 years, that would also increase your risk for dementia. And similarly, when you were over 65 and you had diabetes over 6 to 10 years, your risk increased. Interestingly, when you were 70 years old, your risk only increased when you had a risk for over 10 years. Next slide, please. This study also looked if you had comorbidities, because, diabetes often comes with history of stroke, heart failure, cardiac diseases. And they only found that when you had an increased risk for dementia, when you had diabetes and stroke, and at least 2 other or 3 other comorbidities. So when you had diabetes and or stroke, diabetes with 2 other comorbidities, or diabetes or all other comorbidities. And just for those of you who are not familiar, this model 1, 2, and 3, usually the third model adjusts for all comorbidities. So whenever you're looking at studies, always look for the models adjusting for all the comorbidities. So thank you. Next one. Again, when you look at this is interesting. So diabetes, from one study which showed diabetes can contribute almost up to 3% for the lifetime, life course risk for dementia. So next slide. So these authors were also interested, very often should I worry more about hyperglycemia or hypoglycemia? And what they found, they did a meta-analysis, which means they take all the studies and put them all in one, machine and then look. And what they have found, that hypoglycemia actually increases your risk almost, at least 2 times compared to hyperglycemia. So in terms of dementia risk, hypoglycemia is much more concerning to your patient in terms of dementia risk than a hyperglycemia. Next one. Then, and also another term, what we have found in diabetes, then diabetes length did not play any role in terms of dementia risk. And of course, the same here, when you're diabetic, you're treated with anti-diabetic medication. And there is a lot of interest in terms of the medication, because sometimes they can also play a role in terms of, there was an interest in how, if they are maybe protective, independent of diabetes. And they found that when you look at the top, that any oral hypoglycemic, they found no benefit. Insulin, actually, they found maybe there's an increased risk caused by insulin. Metformin, there's a huge interest, and actually there are now clinical trials looking at metformin to reduce maybe the risk for dementia. But when you look at these studies, this was done in 2018. So a lot of maybe more recent research is missing. Sulfonylurea medications, no benefit. And the thiazole, I have to spell it out. I can never, the TZDs, especially pioglitazone, was found to be beneficial in terms of risk reduction for dementia. Next slide, please. Now, since then, there are the newer medications. A lot of, the newer one, SGLT2 inhibitors, and there are plenty enough that they have done now some meta-analyses. The one here from JAGS showed that actually the newer ones, and they have reduced the risk for developing dementia independent from diabetes. So there must be another mechanism. Next slide. And which one is, this is the DPP4. Different studies looking at all-cause dementia, Alzheimer's dementia, and vascular dementia. And as you can see, DPP4 inhibitors reduce all-cause dementia, but this is mainly driven by reducing vascular dementia significantly. So next slide. So what is interesting, we focus always on medications, but this was, I really like this paper, because dementia risk modification, it came from Hong Kong. So in Hong Kong, they introduced an intervention in 2009. Anyone who was diagnosed with diabetes, they could be enrolled. It's not mandatory, but they could be enrolled in a risk assessment and management program for diabetes mellitus, and to provide cardiovascular risk assessment to detect complications early and enhance diabetes management. And they found that it improved glycemic control, reduced mortality risk over the 9 years by 55%, reduced stroke and heart attack by 48% over 9 years. Next slide. So this study looked also, did it have an effect on dementia risk? So they were able to follow 105,000 patients over 9 years. Of the 105, 73 enrolled in this program, while the 32, they just received traditional care. And when you compare them, there was a significant reduction by around 30% of all-cause dementia, a significant reduction for Alzheimer's disease, 15%, and even vascular dementia by 40%, and even other type of dementia. So just by, getting close dementia care, glucose control, prevention of complication, obviously strokes, and other vascular, we know that renal disease is associated with increased risk of dementia. Just by that, we can reduce the risk. Next slide. Just to sum it up, wonderful. So brain of patients with Alzheimer's disease, the changes start 20 years before symptoms occur. In addition to the amyloid and tau pathology, vascular pathology plays a major role. Vascular risk factors, thank you, including hypertension and diabetes mellitus at midlife are important risk factors for dementia. Alzheimer's medication use has shown mixed results, especially in meta-analyses. However, no or few data are available from midlife antihypertensive medication use and late life dementia risk, and even fewer from preclinical phase. Anti-diabetes medication have shown mixed protective effects. However, few or no studies again from midlife medication use and late life dementia risk, and actually no studies from preclinical phase. And I think I am done. And thank you for your attention. And I'm open for questions, comments, concerns. You're muted.
Terrific. Thank you, Dr. Yassar. We're going to see if there's any questions in the chat.
Yeah, I see it.
Okay.
Yeah, so actually, yes, I wish I would have another 15 minutes because just to package all the vascular risk factors, absolutely. Hyperlipidemia is also one risk factor. And in terms of for Alzheimer's disease and also for vascular dementia. And there's a lot of literature and a lot of interest in statins. There was a concern, and actually the FDA put a black box warning from small studies which showed that actually statins increase maybe the risk of cognitive decline in people already with dementia and dementia risk. But there was one meta-analysis again, which put all these small studies, and it showed that statin indeed did not reduce did not increase your cognitive decline when you already have dementia, and it did not increase the risk for dementia. So if you have a patient who had a stroke or an MI and they have cognitive, impairment, please do not stop statin. So definitely, so that's the story behind it.
Thank you. There's a new message. Thank you. Any other questions for Dr. Yassar?
Midlife and late life. So very good. Late life, it's usually anything below 65, and midlife, it's 40, 50. That is what I would say. So midlife is our 40s, 50s, maybe 60s. And then late life is anything, after 65, 70. And, you have to deal even with our centenary or the oldest old. Those are the 80s. So we cannot treat them actually we should treat them very different, because it has been also shown that hypertension in people who are 80 or 90 is actually protective for people over 80 or over 90. So we have to treat them differently. So then our people who are in their 40s, 50s, who are in their 60s, 70s, and who are in their 90s. So there are numerous studies from the Leisure World study or the 90+ study from California, from the group from Claudia Cuevas, who studies that group very extensively. And it kind of makes sense, you need more, they need more perfusion in their brain. Studies indicate, I read it out. Studies indicate that some statins, lipid solubles, tend to cause dementia symptoms. Have you had any strong concerns, even starting statin in older adults who have diabetes, but have normal lipid values? Oh, I would never start anyone on statins with normal lipid values, well, except if you had a stroke. Yes, so there are different statins, the lipophilic and the hydrophilic. The lipophilic, they cross the blood-brain barriers, and there are different studies, and I'm not prepared to exactly say which one those are. They looked into that, but I don't remember which one, and yeah. Thank you. Pravastatin okay, and rosuvastatin, thank you. So I would only start someone if if they had recently stroke or for secondary prevention. So definitely only for secondary prevention. And I'm sure you all heard now the new studies, that we are maybe over treating. There's a new people with statins, and according to the new calculator, we actually should not treat people with statin as often as we should. Oh, okay, then it's the atorvastatin. Oh, so the pravastatin and the rosuvastatin are the water soluble one. Then obviously the atorvastatin is the most likely, and the simvastatin are the lipophilics. So
Great questions. Thank you. Anyone else have any questions for Dr. Saar? We appreciate your presentation. Thank you very much for a wonderful presentation. I will make your slide deck as well as the recording housed on the Center of Excellence website. Once that is up, I will share the link for access to the slide deck and the recorded conversation. So thank you again all for coming out today. Make it a great afternoon. Thank you again, Dr. Saar.
thank you all. Thank you for the good questions.